Day 0. The nail. You're doing what you've done 100 times before. Cleaning out the garage, moving old timber, clearing out the back corner that's been piling up for 2 years. The floor is dusty, cluttered with old tools and wood scraps, and a decade of accumulated mess. You feel the nail before you see it. A sharp, sudden jab straight into the ball of your right foot, right through your shoe. You pull your foot back and look down. A rusty nail, maybe 3 centimeters long, driven up through a scrap of old wood on the floor. 2 centimeters of it went into your foot. You hobble inside. You run it under the tap, wash it with soap, wince at how deep it is, then slap on some antiseptic and a plaster. The bleeding slows. It hurts, but nothing dramatic. You do not go to a doctor. It's just a nail. You've had worse. Here's what you don't know, and what makes this moment far more serious than it appears. Rusty nails aren't dangerous because of the rust itself. Rust is just oxidized iron. It doesn't cause tetanus. What makes them dangerous is the surface texture that rust creates, rough, porous, and ideal for harboring soil particles and organic debris. And embedded in the soil around that nail, in invisible microscopic clusters, are the spores of a bacterium called Clostridium tetani, one of the oldest and most resilient pathogens on Earth, capable of surviving in soil for decades, resistant to boiling, resistant to most antiseptics, and perfectly dormant until they find exactly the kind of environment your foot just gave them. A deep puncture wound, low oxygen, warmth. The spores are already inside you. They're waking up. Day 2, the window. You've almost forgotten about the nail already. Your foot is sore when you press on it, but the skin has closed over and there's no obvious sign of infection. No redness spreading out, no warmth, no swelling. It looks fine. It isn't fine. Inside the puncture wound, something has already begun. The spores of Clostridium tetani, now in the oxygen-poor environment of a deep tissue wound, have germinated into active bacteria and have started producing a toxin called tetanospasmin. This toxin is their weapon, and it's extraordinary. Released by the bacteria at the wound site, it doesn't stay there. It travels, the same way rabies does, not through your bloodstream, but along your nerve fibers, climbing toward your spinal cord and brain, hijacking the very nerve pathways that allow your muscles to relax. This is the moment a tetanus shot could still stop everything. Not just a vaccine booster, though if you'd had one within the last 10 years, this would likely be a non-issue, but post-exposure treatment with tetanus immunoglobulin, an injection of antibodies that can neutralize the toxin before it reaches your nervous system. The window for this is short. Ideally, you'd be seen within 72 hours of the injury. You are now at 48 hours, and you have no idea. Day 7. The first sign. A week after stepping on the nail, something strange happens when you try to eat breakfast. Your jaw won't open properly. Not completely stuck, not locked shut, just tight, resistant, like the muscles have been slightly over-tightened. You stretch your mouth wide a few times, assume you slept on it wrong, and go about your morning. By afternoon, it's worse. You try to eat lunch and find the motion of chewing uncomfortable in a way that has no obvious explanation. You also notice your face feels odd. Not numb exactly. Stiff around the mouth, as though someone has injected a mild tension into the muscles around your lips. When you look in the mirror, your expression seems slightly wrong. The corners of your mouth pulled back in a faint, involuntary tension, a look some doctors describe as a sardonic grin, rhesus sardonicus, the permanent forced smile of early tetanus. This is the first visible evidence that the toxin has arrived at your nervous system. Tetanospasmin works by blocking the release of 2 neurotransmitters, glycine and GABA, the chemical signals that tell muscles to stop contracting. Without those signals, muscles have no off switch. They contract on command, but they can't receive the order to relax. Starting in the jaw, the smallest, most sensitive muscle group first, and working its way down, you call your doctor's office. The earliest appointment is in 3 days. You book it. Day 8. The neck. By the following morning, the stiffness has spread. Your jaw is significantly worse, and now your neck has joined it. Turning your head is uncomfortable. The muscles feel braced, resistant, as though they're anticipating an impact that never comes. Swallowing has become slightly harder. Not impossible, but effortful, like your throat muscles are mildly reluctant to participate. You skip solid food at breakfast and drink juice instead. Your back has started to feel tight too. A rigidity across your upper back and shoulders that you'd normally blame on stress or posture, except it came on too quickly and too evenly, both sides at exactly the same time. You cancel the doctor's appointment and rebook for today instead, early morning. Something about this doesn't feel right. The doctor presses on your jaw, checks your muscle tone, asks about recent injuries. When you mention the nail in the garage 7 days ago, his expression shifts. He refers you to the emergency department immediately. Not urgently, he says. Now, day 9, the ICU. At the emergency department, a consultant confirms it within about 20 minutes of examining you. Generalized tetanus. Not common, not mild, not something they can treat and send you home with antibiotics for. You're admitted to the intensive care unit. The treatment for tetanus in this stage has no shortcut. There's no antidote that reverses the toxin's effect on the nerves it's already reached. The tetanus immunoglobulin they administer now can only neutralize toxin that hasn't yet bound to nerve tissue, stopping the disease from getting worse, but doing nothing about what's already attached. Then the medical team's job becomes keeping you alive while the toxin already in your system burns through its course, 1 to 3 weeks of your nervous system having no muscle-off switch, managed minute by minute. Your wound gets surgically cleaned and debrided, any dead tissue removed that might still harbor active bacteria. Intravenous antibiotics are started. Muscle relaxants, diazepam at first, heavier sedation if needed, are administered to dampen the worst of the spasms. The room you're placed in is a single occupancy room away from the general ward noise, because stimulus control, keeping your environment dim and quiet, is itself a meaningful part of tetanus management. Every alarm, every loud voice, every sudden light can trigger a muscle spasm, and every spasm is a risk. Then you wait. Day 12. The spasms. 3 days in, the spasms start. They arrive without warning. Generalized, full-body contractions triggered by almost nothing, a sudden noise, a bright light, a touch on the shoulder. Your entire body seizes at once, muscles locking in a rigid arch, your back bending backward, your jaw clenched, your arms pulled inward, your legs rigid. Each spasm lasts anywhere from a few seconds to a few minutes. Each one feels like every muscle in your body has been seized by a single fist. The ward you're in is kept deliberately dim and quiet. Noise and light both trigger episodes. Nurses move carefully around your bed. Your family, when they visit, are told to speak softly, to avoid sudden movements, to not touch you without warning you first. The spasms are violent enough to fracture bones. This isn't a dramatic metaphor. Sustained, involuntary muscle contractions at this intensity can snap vertebrae, crack long bones, tear tendons from their attachments. Medical staff monitor you for exactly this, because it happens. The most serious risk isn't the spasms themselves. It's your airway. A laryngospasm, a spasm of the muscles in your throat, can close your airway completely in a second. You're intubated, a breathing tube placed while your team can still do it easily, because if a laryngospasm closes your airway before they can, the situation becomes immediately life-threatening. The breathing machine takes over while your body fights through what it's fighting through. Day 21, the turning point. 3 weeks after a nail in the foot, the worst of it begins to ease. The spasms become less frequent, then less severe. The muscle rigidity, which has been a constant, exhausting presence for nearly 2 weeks, begins to loosen incrementally. The breathing tube comes out. You drink water on your own for the first time since you were admitted. Your jaw opens far enough to eat soft food. You are not recovered. Not close. The toxin has to fully detach from the nerve synapses it hijacked, a process linked to the natural turnover of nerve terminals that takes months. Your muscles, braced against themselves for weeks, are weakened, fatigued in a way that rest alone won't fix quickly. Simple tasks, lifting a cup, walking to the bathroom unassisted, feel effortful in ways you have no frame of reference for. Physical therapy starts before you leave the hospital. The physiotherapist tells you this is normal. Your muscles remember the bracing pattern. Retraining them takes time. The full recovery, returning to normal muscle strength and function, will take anywhere from 4 weeks to several months. Some patients with severe cases take the better part of a year before they feel genuinely back to baseline. Day 30. The discharge. You go home 30 days after stepping on a nail in your garage. You spent 3 of those days not realizing anything was wrong. You spent the remaining 27 in intensive care. You did not die, which puts you in the better outcome category. Worldwide, roughly 10% of people who develop tetanus do die, even with treatment, primarily from respiratory complications or cardiovascular instability triggered by the autonomic dysfunction that accompanies late-stage disease. In countries without access to intensive care, that number rises sharply. Globally, tetanus still kills tens of thousands of people every year, the large majority of them newborns in regions where maternal vaccination rates are low. The vaccine that would have prevented all of this is one of the most widely available, inexpensive, and effective vaccines in modern medicine. A booster, recommended every 10 years in adults, takes 30 seconds and causes mild arm soreness for a day. 3 weeks of intensive care and months of recovery is what happens when that booster runs out. You never forget that again. You get the shot before you leave the hospital. And somewhere right now, someone is clearing out a garage, or walking barefoot across a garden, or reaching into a pile of old timber without gloves. They feel a scratch, or a jab, or nothing at all. They rinse it. They move on. They'll check their vaccination record tonight, or they won't. And the difference between those two choices is exactly the distance between 30 seconds and 30 days.